All right, today we're going to walk through the journey of someone living with chronic obstructive pulmonary disease, or COPD. We're going to follow the entire path, right from those first symptoms and getting a diagnosis, all the way through the crisis of a flare-up, and then on to the long-term plan for managing it every single day. I want you to imagine something. Try breathing through a really narrow, pinched straw. You can kind of suck air in, okay? But letting it out, that's a slow, tough struggle. That feeling right there, that's the absolute core of what it's like to live with COPD. It is a constant, exhausting battle against your own body, just trying to get the old air out. So, what even is COPD? Well, you can think of it as a 1-2 punch. It's not just one disease, but really a combo of two main problems. First, you've got chronic bronchitis, which just means your airways are pretty much always inflamed and swollen. And second, you've got emphysema, where the tiny little air sacs in your lungs get destroyed. You put those two together, and bam, you've got a permanent roadblock that makes getting air out of your lungs incredibly difficult. Now, when you look at the official clinical definition, there are two words that just jump right out: progressive and persistent. Progressive, well, that means the condition tends to get worse over time. And persistent? That means this whole airflow problem isn't like a cold that just goes away. Nope, it's a permanent change to the actual structure of the lungs. So, how does this actually feel for a person? Well, it usually starts with that constant shortness of breath. The fancy medical term is dyspnea. You might also notice a lot more mucus or hear a wheezing sound. In really severe cases, you might hear nothing, a silent chest, because so little air is actually moving. You'll notice that breathing out takes way longer than breathing in, and people might even have to use muscles in their neck and chest just to help squeeze the air out. Okay, so with all these symptoms piling up, what's next? You have to get a clear diagnosis. But doctors can't just go on what a patient is feeling, right? They need cold, hard data. They have to find a way to objectively measure what's really going on inside those lungs, to see just how well or how poorly air is moving. And the key to unlocking that diagnosis is a test called spirometry. It sounds complicated, but it's really pretty simple. It measures two things. First, the total amount of air you can blow out in one big breath. That's your FVC. And second, it measures how much of that air you can blast out in the very first second. That's your FEV1. See, with healthy lungs, you can force out most of that air almost instantly. But with COPD, that first second blast is way, way smaller. If that FEV1 number is less than 70% of the total, well, that's the gold standard for a COPD diagnosis. So once the diagnosis is confirmed, the next question is, how bad is it? Doctors stage the severity by taking that FEV1 number, that first-second blast we just talked about, and comparing it to what's expected for a healthy person of the same age, height, and gender. This gives them 4 grades, from mild, where your lung function is still pretty good, all the way down to very severe, where it's less than 30% of what it should be. This is so important for tracking the disease over time. But here's the thing, numbers on a chart don't tell the whole story, do they? To really get a handle on how this is impacting a person's life, doctors use what's called the ABE system. It looks past the breathing test and asks 2 really important questions. First, how bad are your symptoms day to day? And second, how often are you having these major flare-ups or exacerbations? Someone in Group E, for example, is considered high risk not just because of their breathing numbers, but because they keep having these crises. This helps doctors tailor the treatment to what the patient is actually going through. And that brings us to the absolute crisis point in this journey: the COPD exacerbation. Now, let me be clear, this is not just a bad breathing day. This is a sudden, terrifying downward spiral where symptoms get so bad they completely overwhelm the person, and it almost always means a trip to the hospital. It is a defining and absolutely frightening moment. So what could possibly push someone into a crisis like this? Well, you'd be surprised. Most often, it's a simple respiratory infection. Seriously? The common cold can be enough to trigger a massive flare-up for someone with COPD. Bacterial infections are another big one. But it could also be something in the environment, like pollution, or it could even be a sign that another huge health problem, like pneumonia or even heart failure, is rearing its head. But get this, and this is just wild to me. For a full 1/3 of these crises, doctors never find the specific cause. The person's condition just plummets, and the medical team has to jump in and start treating it without even knowing what started the fire. And if that's not complicated enough, there's a dangerous imposter that doctors always have to be on the lookout for. In up to a quarter of severe cases, the real culprit isn't a COPD flare-up at all. It's a pulmonary embolism, a blood clot in the lungs.
its symptoms can look almost exactly the same, which makes it absolutely critical for doctors to think beyond the obvious when a patient is struggling this badly.
So the patient is in the hospital, they're in the middle of this crisis. What happens now? The number one goal is immediate stabilization. The team has to get in there, support their breathing, knock down that inflammation, and they'll start with meds but are ready to escalate to serious life support if they have to. The first line of attack is basically a medication cocktail. They'll get blasted with high doses of inhaled bronchodilators to try to pry those airways open. They'll get powerful corticosteroids to fight that raging inflammation. They'll start antibiotics just in case there's a bacterial infection hiding in there. And of course, they get oxygen, but, and this is key, it's managed very carefully. Because believe it or not, too much can actually be harmful. Now, if the medications just aren't cutting it and the patient is getting exhausted from the sheer work of breathing, it's time to bring in some heavy machinery. The first choice is usually non-invasive ventilation, or NIV. That's a tight-fitting mask that helps push air into the lungs, giving the patient's muscles a much-needed break. But if that's not working or they're just too sick, they have to move to invasive ventilation. That means a breathing tube and a machine literally taking over the job of breathing for them. But putting a COPD patient on a ventilator, it's not as simple as it sounds. There's this incredibly dangerous complication that can pop up called auto-PEEP. Remember that pinched straw from the beginning? It's the exact same problem. The ventilator can easily force air in, but because those damaged airways still can't get the air out fast enough, a little bit gets left behind with every single breath, and it just starts to stack and stack and stack, trapping more and more air until the pressure inside the chest gets dangerously high. And this trapped air? It's a massive problem. The pressure builds up so much that it can physically start to squeeze the heart and the major blood vessels. This can literally stop blood from getting back to the heart, which causes a catastrophic drop in blood pressure. It's a condition called shock, and it can be fatal. So how do the doctors and nurses solve this pressure cooker problem? Well, it's all about playing with time. They have to change the ventilator settings to give the lungs way more time to empty out. They'll slow down the number of breaths per minute, and they'll make the exhale time way longer than the inhale time. In a real true emergency, they might even just disconnect the ventilator for a second and gently push on the patient's chest to manually force all that trapped air out. Okay, so the patient made it. They've been through the ringer, they survived the crisis, and they're out of the hospital. Now what? Well, this is a major turning point. The entire focus has to shift from just surviving the day to being proactive and doing everything possible to prevent another one of those crises from ever happening again. And for anyone who's been hospitalized for a flare-up, the foundation of their long-term care becomes what's called triple therapy. It's an aggressive, around-the-clock combination of 3 different long-acting inhaled medications. Together, they work 24/7 to keep the airways open, relax the muscles, and control that underlying inflammation. But inhalers alone are not a magic bullet, not even close. The real game changers are all the other pieces of the puzzle. Quitting smoking is, without a doubt, the single most important thing a person can do. It can slash the frequency of flare-ups by 1/3. That's huge. Then there's pulmonary rehab. It's like a specialized workout and education program that helps rebuild strength and teaches you how to breathe more efficiently. That usually starts about a month after leaving the hospital. And for some people with frequent flare-ups, other daily meds might be added to the mix. So this leaves us with a much more hopeful question, doesn't it? The journey with COPD is, no question, incredibly challenging, and a crisis can feel like it takes over everything. But it doesn't have to be the end of the story. With really proactive care, dedicated rehab, and some big lifestyle changes, the focus can shift from just surviving to actually living well, from simply trying to catch a breath to truly thriving.